So I think that when we speak about NTRK gene fusions, in fact, we have a few things to take into account for the discussion. First of all, it's those alterations are tumor agnostic. And we have several fusion partners and maybe some that we already don't know, and inconsistent breakpoints. And also, you will see that we have two genes, NTRK2 and NTRK3, that harbor large intronic regions. So this is something that can be problematic for the screening. Also, those chimeric genes, they have low complexity GC-rich sequences, so this can lead to problem for DNA sequencing. And for immunohistochemistry, we have some TRK fusion protein that are endogenously expressed in some tumors. So all those things are together, agnostic, the type of fusion, the large intronic regions will impact on the testing strategy. So one thing that could be interesting in terms of testing and pre-selection, we will also discuss that in the breakout sessions, but is that it's an oncogenic driver, so it's supposed to be mutually exclusive from other driver gene mutations, such as, for instance, ALK and BRAF, for what we know for the moment. But as we are collecting data right now, I think it's something that is very important to have in mind. So testing, of course, will be very important, and we have several techniques that can be used, and I'm going to go through them. And next slide, I will start with immunohistochemistry. So immunostochemistry can be of a certain help because looking at the type of subcellular localization of the signal can help us to consider the type of underlying alteration, and especially if we have a nuclear staining, it's something that we usually find in the NTRK3 TV6 alterations. Moderate to strong diffuse cytoplasmic staining is more frequent in the other NTRK1 and NTRK2 fusions, but nothing is really specific. And immunohistochemistry, of course, is a technology that is bread and butter for the pathology labs. It's something that is less expensive. It's reimbursed in many countries with a fast turnaround time. And there is this sub-localization that can be of help. But you have to keep in mind that it's not ALK in lung cancer, so it's not because you have an overexpression that you will have for sure a fusion. So it's really something that is a screening tool, a triage tool, and we know now that some fusions are leading to a low expression of TRK protein, so we can have false negative results. As I mentioned previously, we can have a constitutive expression of or low expression non-associated with fusion, and especially nervous or neuroendocrine tumors, where immunohistochemistry is not at all a good screening tool because almost everything is positive. And it's the same thing for some sarcoma, where we have heterogeneous sarcoma, heterogeneous staining, sorry. And of course, it's not specific because we need the biology molecular results to know about the exons and the partners. And it's, of course, only looking to TRK protein. Fish now. So for fish, we use the break-apart probes. We need to use one for each gene. It's a technology that we have been using for many years, especially for NTRK3, for some specific subtypes. It's a technology that is quite easy to interpret when you are used to it, looking at the separated signals. It cannot confirm the in-frame functional fusion, but it's something that pathology labs are used if, for instance, if they work in lung pathology. So it's a technology that has also a fast turnaround time, 1 or 2 days. but as I said, we need one test for each gene, and we cannot confirm that the fusion is in frame, it's functional. And some reports, especially in pediatric tumors, have showed up to 30% of false negative results. Now we can use technology like RT-PCR or nanostring technology, looking at the transcripts. It's something that is quite inexpensive and a technology that is relatively easy to use, but in fact, you have to pre-select what you are looking at. So today it's probably limited because we have too many TRK fusion partners and we cannot detect novel fusion partners. And this means that if we have a negative result with RT-PCR, we cannot exclude that we don't have any TRK fusion. So it's okay if we look, for instance, to ETV6 and TRK3, something very specific. Otherwise, we have a high risk to miss patients. So NGS, as I said previously, you can see here NTRK1. We have very few introns, but NTRK2 and NTRK3 have extremely large intronic spaces. This can be a problem because we will have to go through those introns. It's a complexity for sequencing, and we need also to multiplex to get appropriate coverage. And it's a nightmare in liquid biopsy, those large intronic area for NTRK2 and NTRK3 because of the quality of circulating DNA. So NGS in general is probably the best option for NTRK, because also we can look to other drivers. So we have this possibility of multiplexing and to have an all-in-one test. And for NTRK, it can detect both known and novel fusion, regardless the breakpoint and the fusion partner. But today we consider that RNA-based NGS is a preferred method for detecting NTRK fusion in cancer, because we can detect the in-frame transcript gene fusion, and also because it avoids the difficulties of sequencing large intronic regions in the NTRK gene, so especially for NTRK2 and NTRK3 gene fusions. This is highlighted by this study from Memorial Sloan Kettering Cancer Center. They, in a series of more than 2,500 lung adenocarcinoma, so they started with the MSK impact, so DNA, the DNA NGS, and they found 7.7% fusion. And in the 254 cases driver negative, they did RNA-seq. And in those patients, they found an extra 25 in-frame fusion, including 2 cases with NTRK fusions. And the patient were treated by larotrectinib. And one of the patient had the patient were able to be treated and responded. So in conclusion, unfortunately, the perfect NTRK fusion test does not exist. Each approach has pros and cons, and we will see the aspect with the algorithm. NGS, of course, is the probably the most comprehensive, hypothesis-free. It's an all-in-one solution, but it's not available everywhere, and it is expensive. So it will depend a lot on what is the strategy for the tumor group. And in the NGS, RNA NGS is preferable. RT-PCR is a targeted research. It's a very simple tool, but it's only detecting the fusion you know and you are looking for. So just for very specific alterations. For fish, It's useful for the pathognomonic NTRK positive cancer. It's something that we have been using for many years as pathologists for the diagnosis of, for instance, secretory breast cancer. But we have to know the limitation, and we have to use 3 different probes. And immunohistochemistry could be a very interesting screening tool, but of course, it's even if we have a high level of expression, today we need to have a confirmation by NGS or FISH or RT-PCR if we look to a very specific alteration. So this has an impact on the strategy for fusion. And I remind you that we have 4 tumor types with a very high level of TRK alteration that are pathognomonic of them. And in other tumor types, the fusion are extremely rare, maybe with the exception of papillary thyroid cancer, schistoid tumors, and some pan-negative GIST, where we can have up to 5 to 25% of NTRK fusions. So this will have an impact on the screening, of course. So in terms of testing algorithm, if we start from the left, we have the category of the tumors with high NTRK gene fusion frequency. So the pediatric tumors and the salivary gland mammary-like and the secretory carcinoma. In those cases, in fact, we do what we were doing before. So usually we were doing FISH to confirm the diagnosis. Today we can also use pan-TRK immunohistochemistry, and it's really recommended, especially if we use pan-TRK immunohistochemistry, to have a confirmation by NGS. And if we have the impression that it is one of those 4 tumor types, and if immunohistochemistry is negative, my recommendation is to do molecular biology to be sure that we are not missing a patient on that. For the other tumor types, it will depend on what is the strategy, the diagnostic strategy today. And we know that we had guidelines from ESMO, for instance, for the use of NGS in routine. And it's not recommended for many tumor types, but it's, for instance, recommended for lung cancer. So if we perform NGS routinely, we need to add to our NGS routine the possibility to screen for the fusions. It will be also the case, in my opinion, it's very interesting to do that for thyroid cancer. So we will do NGS and look at the presence or absence of fusions. If NGS is not routinely performed, we can use immunohistochemistry as a screening tool, with the exception of neurologic tumors or neuroendocrine tumors, where immunohistochemistry will not be interesting because of the high level of positivity. We can look at some testing guidance in some of the options that we have, for instance, in lung, colorectal, thyroid, and sarcoma. For instance, in lung, the ideal is to test the cases by NGS, including RNA for the fusion. So you can also cover AL, CROSS1, RET, and NRG1, and NTRK. Or the alternative will be to screen the tumors that are negative for the major driver and look for the fusion or for NTRK fusion specifically, regardless of PD-L1 status. For colorectal cancer, ideally, it will be to do an all-in-one test, but it could also be restricted to at least all the MSI-high patients, or to the patients that are wild type for KRAS, NRAS, and BRAF. For thyroid cancer, of course, we are not going to test all the thyroid cancer because of the excellent prognosis, even in the metastatic stage, but the patients that are radioiodine refractory, or we can start with the patients that are, if we cannot test all of them, at least test the patients who are not BRAF mutated. And for the sarcoma, we recently published the guidelines. So we know that the type of sarcoma, general sarcoma, where we have the most alteration are in the GISTs. And of course, it's interesting to look at the genes that do not harbor the other driver like KIT, PDGFR, SDH, and F1. But also you can look to the other sarcoma without the drivers. We have also specific algorithms that are published today with other type of sarcoma, for instance, for the uterine sarcoma. So I think that the more knowledge we have, the better we will be to screen in the different clinical condition. And the ideal will be the RNA-based NGS, but then we will be able to go to immunohistochemistry to screen for many of the patients if we don't have first access to NGS or to fusion NGS. So with that, I think that this is my conclusion slide. So here we are going to screen for extremely rare molecular events. We have several options. So NGS is broad and can detect many mutation, copy number variation, certain rearrangement, and MSI status. Mutation and fusion-specific immunohistochemistry have the advantage in small sample or low tumor content cases. And RNA testing can identify a variety of fusions in driver-negative cancer. And immunohistochemistry represents an interesting screening tool for frequent tumor, but some limitation exist. And also immunohistochemistry for PanTrek is extremely sensitive to fixation. Thank you.